Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this podcast episode, we're talking with an expert on new treatment modalities for cardiogenic shock. Before starting, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, 1 in 5 people will develop heart failure in their lifetime, and half will have preserved ejection fraction, HEF, which is becoming increasingly prevalent. The other half have heart failure with reduced ejection fraction, so-called HEF-REF. Separate to these two entities, an extreme form of heart failure is cardiogenic shock, and this most commonly occurs after acute myocardial infarction, AMI, and complicates AMIs in 5 to 10% of cases. Cardiogenic shock is a clinical syndrome characterised by decreased cardiac output resulting in end-organ hypoperfusion and tissue ischemia. And patients presenting with ST elevation myocardial infarction, STEMIs, are twofold more likely to present with cardiogenic shock than those presenting with a non-STEMI. Cardiogenic shock carries a poor prognosis and is the leading cause of death in patients with acute myocardial infarction. And about 80% of patients with cardiogenic shock die despite optimal treatment, usually from complications including dysrhythmias, cardiac arrest, renal failure, ventricular aneurysm, stroke, and thromboembolism. And treatment modalities include medical resuscitation and pharmacologic management, primary percutaneous coronary intervention, urgent coronary artery bypass grafting, and artificial circulatory support, drawing upon intra-aortic balloon pumps and extracorporeal membrane oxygenation, so-called ECMO. Additionally, there are non-intra-aortic balloon pump percutaneous mechanical devices, as well as cardiac transplantation to consider. Now, these treatments have reduced in-hospital mortality over the last 20 years. However, cardiogenic shock patients who survive to reach hospital discharge still have a higher rate of mortality post-discharge than uncomplicated AMI patients. Well, some exciting new developments are afoot, however, with the recent introduction into clinical practice in Australia of the microaxial pump device. Now, I was curious to learn more about this subject and new approach to management, and was privileged to have this conversation on the subject with expert cardiologist Dr James Saponti, who's been kind enough to join us previously. Now, James has been involved with some of the steering committees related to cardiogenic shock management and works actively as an interventionist at many sites in Melbourne, including St John of God Berwick and the Victorian Heart Hospital. Now, please welcome James to the podcast. Dr. James Saponti, great friend, great cardiologist, someone I lean on whenever I have any patient who's got cardiac issues. And James, you never fail to impress both myself and my patients. We've had you here before as a guest on Everyday Medicine. We're welcoming you back because today we want to talk a little bit about the new treatment modalities for cardiogenic shock, and it's something you've got an interest in. We are very keen to hear where this whole field is moving. We're opening a forum up to you, James. Educate us, take us through it too.
Thanks, Luke. Thanks for having me back, and it's always a pleasure to be on Everyday Medicine. I enjoy it just as much as I'm sure your listeners do. So I've decided to talk about this topic, and I have spoken to you a little bit about this in the past, but the importance of this is really a very unique area of medicine, and that is those patients that enter the hospital with cardiogenic shock requiring CPR, requiring aggressive therapy, inotropic therapy to improve their heart function. Just to give you an idea, over the last 50 to 60 years, the only real treatment we've had to improve outcomes in patients that come into the hospital that have, for example, arrested after a heart attack is to place a stent into one of their arteries. Despite this new technology showing some benefit, we still have something close to a 65% mortality rate of those patients coming in the hospital. And that means that if you had a cardiac arrest with a heart attack external to the hospital itself, 60% of those patients, 2/3, will actually die within 30 days, if not 6 months. Mm-hmm. So even though the ambulance officers may be able to regain consciousness and regain blood pressure, if the patient isn't conscious, then it's unlikely they actually make it out the door. And we have, as cardiologists, been looking for alternative ways of being able to treat these patients. And despite the use of inotropic therapy, ICU, very advanced techniques, nothing has really budged that needle towards improving outcomes until more recently. Just to backdate this a little bit, there has been a new piece of technology called a microaxial pump that has recently been developed through Germany via a company called Johnson & Johnson, who currently now own that. This pump works like an Archimedes screw and essentially is a tube, probably the thickness of your pinky finger, that enters through the leg into the left ventricle. That Archimedes screw or spiral spins at very fast revolutions, sucking the blood out of the left ventricle and pumping it into the aorta. And it's a tube that we can put into a patient very, very quickly. In the past, we were trying to use this on certain patients that did come in with cardiogenic shock, but it was still unsuccessful. And it wasn't until the most recent cardiac conference showing the results of the new trial that's just been released called the Danger Shock trial did we discover that this device has its place in certain people with cardiogenic shock. This Danger Shock trial was extremely difficult to run. It took one whole decade to get the patients out, and only a total of 300 patients were in the trial. The reason for this is that we've discovered over time that shock is not only the most important thing when it comes to patient outcomes. In fact, a lot of the times you can actually get your heart restarted with an appropriate blood pressure and very little heart damage. But if the patient has had a long downtime, that means a long period of time without blood supply to their brain, the most common cause of death in that situation is actually brain death more so than cardiac death. So by being able to differentiate these two patient groups, we then focused all of our attentions onto those patients that had a out-of-hospital cardiac arrest, were able to be resuscitated, regained some form of consciousness, and then were taken into the hospital. What happened then is 50% were obviously randomized to the standard medical approach, which is just a stent and then subsequently medical therapy, and another 50% were given the standard medical approach, including a stent plus this microaxial pump. And we were able to improve outcomes at 6 months by about 11 to 12%, which means the total number of patients you need to treat to save one life is close to about 7 patients. Despite this seeming really, unremarkable in any way, when you are dealing with large centres, such as, for example, the Victorian Heart Hospital that's just opened up, dealing with 1,000 infarcts per year and dealing with over 250 cardiac arrests per year, you're talking about survival in more than 15 patients, probably even 20 patients now surviving more so. So it has been a landmark trial, and it's slowly starting to change the way we are starting to think about cardiogenic shock in this patient group. In fact, there is evidence now pointing out to patients coming in with heart attacks and cardiogenic shock that we actually leave the heart attack alone and we actually start treating the heart function, the LV function, before we start opening the artery. And it begs to ask the question is, why do patients get cardiogenic shock? And this is an important point that I speak to my fellows and my registrars about, and that is, why can a person have a heart attack, present to hospital, have a stent and go home in 3 days? And why does the next person have a heart attack, arrest and die before reaching the hospital when fundamentally the pathology is the same? And this is the information that we're starting to understand with these microaxial pumps, understanding what the patient was like prior to the heart attack. And we're knowing that people that are more sick, for example, obesity, diabetes, multi-vessel disease, previous heart disease, generally do a lot worse in these situations. And then the cause of the arrest in the vast majority of times is not just the occluded artery, but the occluded artery causing arrhythmia. And it's the arrhythmia that really causes the problem more so than the occluded artery itself. So it is a new method of evaluating these patients and steering away from where our classically meant to, treat these patients with just simple stenting and hoping they're getting better. Hopefully they get better. But now we're able to assist the ventricle in a way to be able to offload a lot of this thickening and dilation that happens inside the heart itself.
James, I'm fascinated by this. This is where I get very excited about cardiology, because cardiology seems to be just pushing ahead all the boundaries. Oncology perhaps is a bit the same, where some of the other specialties, mine included, lagging behind a bit. You've got the sexy specialty, really. But with that Archimedes style pump that you're referring to, is that something that you leave in for a prolonged period of time, or is it just used for a very short period of time, like 24 hours, 48 hours?
So theoretically, it's supposed to be a short-lived device, but working over in the US, we had these devices in patients for up to 200 days.
Okay.
So it's off-label use, but can be used. And it not only can be used in acute cardiogenic shock, but also in patients with, for example, very bad heart failure, that have come into the hospital decompensated,
yes,
and needing the heart function to improve acutely. Prior to this technology, we used to have to perform surgical LVADs on these patients, which meant that the patient had a continuous lead exiting the body requiring battery operation, whereas these can be put in for a short time, offload the ventricle, can be just removed completely, and the artery can be sewn up and they go back to normal work.
So there are left ventricular and right ventricular assist devices. Is this something that's going to maybe replace those, at least in the short term? Someone maybe who's going to have a transplant.
To a degree, maybe, Luke. I think the Australian government is now looking at these left ventricular assist devices. They're called percutaneous left ventricular assist devices, because they are simply put in percutaneously, as mentioned. But the MSAC group is now looking at trying to introduce an MBS reimbursement number for this device. So, doctors out there may see discharge summaries where these patients may have had these devices placed in. The hard component of all of this is the health economics, because you can probably imagine these devices are not cheap in any way, shape, or form. A single device can be a better part of $60,000. And that does not include monitoring the devices as well. And this is where the problems were with this trial originally. How do you justify putting a $60,000 device in a patient that is more likely going to die? Okay, and you can't just start putting these into everybody, because we know these patients coming into the hospital have a 60% mortality rate. That means 2 in every 3 $60,000 devices you're placing into a dead person.
Mm-hmm.
So it's more important to be able to really understand which person requires this device at which time.
Yeah, careful selection.
Absolutely, and I think this is key about this type of technology moving forward. And it's been a groundbreaking understanding to see that. And I try to teach this to a lot of the other interventionalists, cardiologists, is when cardiogenic shock occurs, it is a spiraling effect. After you start CPR, the heart has already failed. It is not going to fail. And every single ionotrope that is actually placed on the patient increases their mortality and decreases their survival. A single ionotrope has a worse outcome. 2 ionotropes has a really bad outcome. 3 ionotropes, and you'd be very lucky to make it out of intensive care. So in the past, where we have used ionotropes, we are now understanding that they're basically very much palliative, more so than therapeutic.
Right. Yes. Are we doing this at the moment in Australia? Is it about to start, or has it already started with you, James?
So it's already started, and we are starting to now subspecialise in this area. And in matter of fact, you might see a lot of your hospitals starting to develop things called shock teams. And that is a special group of heart failure experts, cardiothoracic surgeons, and interventional cardiologists that will be rung or consulted about if a patient is in shock. And those team members come in when those patients enter the hospital and subsequently work on the patients in terms of their shock component, whereas the interventional cardiologist alone will be looking at opening up the artery. So you potentially have two teams coming in for a single patient. The device is now available throughout a lot of the hospitals in Melbourne, the Alfred, the Western, etc., and in some private hospitals. It's also used in Western Australia, Sydney and Queensland, and they're starting to develop the device in South Australia. So it will become more and more common. There is a right-sided device as well instead of just a left-sided device. This is also very important in heart transplant. When we think about heart transplant, the most common cause for failure of transplant augmentation is actually right ventricular failure. And believe it or not, even though the left ventricle is probably the most important and well-known chamber of the heart, the right ventricle is the most difficult to treat when it does fail. So this technology is going to transfer over to that more difficult area of cardiogenic shock in the future. So the trials are undergoing with that now currently as well.
Can you also clarify, someone comes in with cardiogenic shock, there's going to be a lot of assessment being undertaken. There's a lot of activity that's being put into keeping that patient alive. How long, on average, does it take before one of these, once decided that the patient needs one of these pumps, microaxial pumps, how long roughly before the pump is inserted? Is it something you do within the first 2 hours, 3 hours, or 4 hours, or does it?
So yeah, look, it's a good question. In fact, I am pushing to place the pump almost at the door
Really?
of the hospital.
So it's one of the acute interventions that you have to
absolutely
have in your mind.
The faster you get that pump in, the better the patient outcome will be. And in fact, in Paris, they have pumps in the actual ambulances, and they place the pump in the patient before they arrive to hospital, so that by the time the patient gets onto the cath lab table, this device has already been working for 30 minutes. So the heart itself isn't congested. It hasn't got a very high end diastolic volume or pressure. And the concept is that one of the things I'll just take a step back is when a patient is in cardiogenic shock and you open their artery, you cannot actually fill the artery with blood. And the reason for that is that the ventricle is failing so badly that the amount of blood within the left ventricle is very high. That causes the wall of the ventricle to become quite stiff. A stiffened wall of the ventricle is what we call a very high end diastolic pressure. And I don't know if you remember your medical school days, but coronary perfusion pressure is the direct relationship between your mean arterial pressure and your end diastolic pressure, meaning that your blood pressure has to be higher than the pressure inside the wall of the ventricle in order for that blood to leave the aorta and penetrate the muscles.
Yeah. Okay.
If your pressure inside your muscles is higher than the pressure of your arterial system because you're in shock, then that blood will not enter the myocardium, therefore the myocardium becomes deficient in oxygen, which causes a higher pressure, which decreases your blood pressure, and subsequently you spiral downwards. So the concept is that even before you open the stent, so the artery with the stent, reducing the pressure in the wall of that ventricle is vital, because it doesn't matter.
Yeah,
exactly. Even if your arteries are completely open, if your pressure is too high, the blood won't flow there. So the key is early as possible.
Well, that's fascinating, James. Thanks for bringing us up to speed on this. And, we're so lucky to have you and other interventionalists here in Victoria saving lives and, bringing these new technologies to us, James. So thank you very much for that very erudite review of this fascinating subject. Look forward to seeing you again soon. Thank you.
Thanks, Luke. Cheers.
I'd like to thank you again for joining me in the podcast today where we discussed cardiogenic shock with the expert Dr James Saponti. It was very generous of him to spend so much time again talking on this new subject with us, and I hope you've gained some valuable insights. And next week we'll have another very interesting guest, and during the podcast series we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients but as general information only and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@gihealth.com.au.